So I think it's helpful to start with a case, and this is someone I take care of now, 20 years later. So at the time, this person was 17 years old, presented with progressive hearing loss, first to their pediatrician and then to otolaryngology, and finally to me. At their otolaryngology evaluation, they had an audiology evaluation that showed 70% word recognition on the right and 10% on the left. And those of you familiar with people who are diagnosed with NF2 schwannamatosis will know that the scan is going to be flummoxing, in that the side with the best hearing has the largest, most complicated tumor, and the side with essentially no operational hearing has a more approachable tumor. And this is the conundrum we find ourselves in with most of our people who live with NF2 schwannamatosis. I'll just continue the story for this particular individual to highlight some other points, which is that unlike people who have sporadic vestibular schwannomas, we have multiple other pieces on the chessboard that at some point in their lifetime are going to become active. And I'm specifically highlighting this person who's 17 because if this was a 70-year-old and these were the problems, you have what you have, and probably there won't be substantial progression. But in a 17-year-old, there will be progression of these issues, and then we have to consider all of the challenges and threats in front of us as we address the hearing challenge. So what's the definition of NF2 schwannamatosis? The definition, here are the statistics. It is defined by bilateral vestibular schwannomas. I put these images up here to show you how different bilateral vestibular schwannomas can look. From this image to this image, both of these people are showing up for their first diagnosis, and that's what their first MRI looks like. It is caused by an autosomal dominant variant in the NF2 gene. It affects about 1 in 25,000 births. The average age of onset of symptoms is in people's 20s, but they might not present to clinic until their 30s because the onset of symptoms can be somewhat subtle. And almost all people will develop bilateral vestibular schwannomas by their 30s. And why that matters is if you're struggling to make the diagnosis, you can be pretty confident that if you're seeing someone in their 30s and they don't have bilateral vestibular schwannomas, that rules against conventional germline NF2. I'll come back to that in a minute. The tumor types are the bilateral vestibular schwannomas that I mentioned, but also multiple meningiomas, both intracranial and paraspinal, as demonstrated here. On the next slide, I have some paraspinal ones. And non-vestibular schwannomas on any of the cranial nerves, fortunately, that's dictating too much. Fortunately, the non-vestibular schwannomas rarely cause problems, but the big exception to that rule is cranial nerve 7, which is one of our major priorities in protecting cranial nerve 7 in people with NF2 schwannamatosis, and then the ependymomas, which again, fortunately, rarely require intervention, but we have to keep our eye on them. So this is a really helpful review of how people present in terms of their symptoms. The most common reason someone presents to the doctor who has a diagnosis of NF2 is unilateral hearing loss. They almost never present with deafness. They will present with one side showing progressive decline. And I have a hypothesis that we're seeing people earlier because of our reliance on things like ear pods and kids noticing earlier in life that they can't hear on one side versus the other, but I haven't done that study yet. In children, we see focal weakness, like a foot drop or a weakness of one digit on their hand as the original sign, and then you can see there's a spattering of distribution otherwise. But importantly, 11% of people in this one study were found because they had an affected family member, and we did screening with MRI. You think we'd be farther along with treating this condition because we know the chromosome, we know the range of pathogenic variants on this chromosome, we know the product of that chromosome is the protein Merlin, we know it's a tumor suppressor gene. That means that in people who have germline NF2, they are born with one altered copy of the NF2 gene in every single cell everywhere in their body. And then over time, they acquire an additional loss of heterozygosity in the second allele, and that allows tumor to grow. So every place you see one of these red arrows, there has been a biallelic loss of function in the NF2 gene, and every place there's not a tumor showing up here, there has not yet been the second hit. I already mentioned the multiple tumors throughout the neural axis. But there is a really remarkable range of severity. So if you take all people who meet the diagnostic criteria, the severity of both the tumor manifestations that you see on an MRI and what they experience is highly, highly variable. And I'll get into that a little bit. But one thing I want to introduce that has been new and developing since 2017 was brought to us by the team in Manchester, England, and that's this genetic severity score. And what that speaks to is that unlike NF1, an entirely different tumor predisposition condition, but unlike that one where we have very little genotype-phenotype relationship, in NF2, there is a genotype-phenotype relationship. And I really encourage anybody who's interested to go look at this paper. It's not something I could put easily into slides because it depends on what portion of the gene is altered. But I can say there is very mild manifestation. A few tumors, slow to progress, probably won't need any treatment until their 40s, 50s, or 60s, if you're in this mosaic category, and very severe phenotype when there has been a complete truncation of the gene, meaning there is no or very little Merlin protein available in the body. And these are the people who present in childhood and have rapid progression of their symptoms. So it's worth, in between, there are a whole list of exons that you have to go look for a specific splice site or point mutation for the missense mutations, but it is helpful in helping prognosticate for our patients. So this is what I was referring to when I was talking about the new diagnostic criteria. These just came out last year and this effort was led by my friend and colleague, Dr. Scott Plotkin, and you're going to see a lot of slides courtesy of Dr. Scott Plotkin because he really is leading the field in these genetic diagnostics of the Schwannamatoses. And big picture, what this is saying is we used to, in the beginning of time, there was NF1, it was called von Recklinhaus disease. And then NF2 came along, or it was always there, but they were confused together. NF1 and NF2 were confused together. But NF1 and NF2 have nothing to do with one another, except that they are genetic, that they involve tumors of the nerves, not the same tumors of the nerves, but otherwise not the same gene, not the same protein, not the same tumors or manifestations. And so the literature is very confusing about NF1 and NF2 having overlap. In fact, they have no pathophysiologic or molecular overlap. In contrast, about a decade ago, the entity of Schwannamatosis started to be better defined by identifying two specific germline alterations that led to a condition in which there are multiple schwannomas throughout the whole body, but we did not see vestibular schwannomas. At least initially we thought we didn't see vestibular schwannomas. This LZTR1 was literally just described for the first time ever 8 years ago, and now we do see that we can see unilateral vestibular schwannoma in LZTR1 schwannomatosis, and in SMARCB1 schwannomatosis, we still have yet to identify vestibular schwannoma, but we do see intracranial, non-cranial nerve 8 schwannomas, and we do see meningiomas. So big picture, you can see how there's a lot of overlap between SMARCB1, LZTR1, and NF2 related schwannomatosis for a random person walking into clinic. They could come in with a unilateral vestibular schwannoma and a bunch of other schwannomas and have either LZTR1 or NF2, or they could come in with meningioma and non-vestibular schwannomas and have either SMARCB1 or NF2. And now we are starting to realize there are other manifestations, including this GGCR8, which is a choroid plexus papilloma. This we have not been so confused about because we don't see the classic manifestations like meningioma and intracranial schwannoma in this condition. And there's this CDKN2A condition in which there can be non-cranial nerve disorders and neurofibromas, but it's not on chromosome 17, which is NF1, or chromosome 22. And then there's this bin that we're holding everything else in, which is alterations in chromosome 22 that can look like NF2 related schwannomatosis. You do not need to understand all of this. We are still trying to understand all of this. What you need to know is who you think has NF2 may not have NF2, and who you think may not have NF2 may indeed have NF2. And so that is why I'm going to make a pitch throughout this entire presentation about the importance of genetic testing. So here are the current diagnostic criteria for NF2 schwannomatosis. I don't like these because when I was going through medical school, I really liked internal medicine, but I didn't like diagnostic criteria where it said, like, if it's a full moon and you have brown eyes on a Tuesday, then you might have rheumatoid arthritis. And here we are with these major and minor criteria. But big picture is, if you have bilateral vestibular schwannomas and you've confirmed they're bilateral vestibular schwannomas, there's no possibility of this being a leptomeningeal process or something else, then you hit the diagnosis. Or you get the pathogenic variant diagnosed in 2 distinct tumor tissues, or then you have to have 2 major criteria or 1 minor. And again, all of this is to say that there is a lot of overlap between Schwannamatoses conditions, specifically LZTR1, SMARCB1, and NF2. So again, involve a genetic counselor. When you think you're seeing somebody with NF2, if they have not had that confirmed diagnosis, involve a genetic counselor and get genetic testing. Okay, natural history of hearing loss in people with NF2. This is a great deal of the work that has defined this was done at your institution. So I have some anxiety about presenting your data to you, but I'm going to do it anyway. And so this natural history data indicated that from the time of diagnosis, and of course people come to diagnosis at all different time points for a variety of medical and social issues, but from the time of diagnosis, there was a median time to vestibular schwannoma growth of 14 months and a median time to hearing decline of 62 months. I want to point out 2 things. One, this isn't hearing loss, this is hearing decline. And second, you can see the discrepancy between vestibular schwannoma growth and hearing loss. And all I'm going to say is that's the truth, that the size of the vestibular schwannoma and the rate of growth do not directly correlate to hearing loss. It would be nice if they did, because that would make things a lot easier for prognosticating and knowing when to initiate a treatment, but they do not. They are related such that the most people with NF2 will have hearing decline, some people more rapidly, perhaps those truncating mutations, some people much more slowly, truly not until their 60s or 70s, perhaps those are the mosaic, but they are not directly related to tumor size. And another thing I want to point out, which is really important when we're first meeting somebody who's just been diagnosed with NF2, is that if you look at this data that shows the time to hearing loss from 76 ears, not people, but ears, the rate of hearing decline at 3 years was in 16% of the ears. So there is an absolute hearing decline over time, but it is a slow decline. And why I'm saying that is I have not yet had the experience in doing this in 22 years that anyone needed an emergency intervention because of their NF2 associated tumors. They might need a rapid response. You might have a window of opportunity to act, but I have never seen someone admitted to the ER and must have surgery the next day. There's always time to have a conversation. So, yeah, so I want to just add that I think now there's room to look at these pathogenic variants, like I talked about, that genetic severity score. And interestingly, that same group in Manchester, because they have a centralized medical system where people are referred to only, quote, NF2 specialty centers, they have some data on when care is provided at a specialty center versus not a specialty center. That's only in one setting in the world, so I'm not sure how accurate that is, but it is worth saying that the multidisciplinary conversation is helpful. And then the last thing I'm going to say is from this original natural history data is that I said that there's not a direct relationship between tumor size and hearing loss, and that is true. You can't sit with one patient and say, because your tumor is this size, you will have hearing loss in 12 months, 24 months, 36 months, but you can see there is an overall relationship that the smaller the tumor, the slower the hearing loss, the larger the tumor, the faster the hearing loss. And I want you to see the median of that, which is about in their 30s. More about that in 1 second. Okay, so this is similar data, that some of that data that I just showed you was brought into another natural history study in which they then looked at the rate of tumor growth depending on if the tumor was less than 1 cc at the time of diagnosis versus greater than 1 cc. And you can see there wasn't a difference between the tumor size at diagnosis and growth rate, but all tumors grew over time. And there seems to be a peak area of growth somewhere in the 20s to 30s. Not definitive for a person sitting in front of you, but worth thinking about that, you know, if you're seeing someone who's really young, that's a nice person to look for a truncating mutation in. And if you're seeing somebody who's in their 30s, 40s, they're probably not going to have super rapid growth. Although, again, this is not person-specific data. And then again, the hearing decline looks very similar to the last graph I showed you, where if the tumors are greater than 1 cc, there's a more rapid hearing decline versus if they're less than 1 cc. And I'm pointing out something else here, which is to show you the age range where there are major drops in hearing. So there's this one group that's at age 10, and those are, we do not know this for sure, but I hypothesize that those are the people who have a truncating mutation. And these are also the people for whom thus far no drug therapy has been effective. These are the population that I wish we could diagnose early and help them get into the hearing impaired community, the schools for the deaf, and that really rich supportive community, because the next population you see is the drop off at early to mid 20s. And the problem here is that by this time you're out of college, if you were going to go to college, and you're mostly in a hearing world. And now you are the isolated person who doesn't have hearing. And you can imagine how much more that becomes confounding if you're in your late 30s, early 40s. Okay, so it'd be really nice to be able to predict that hearing loss. How would we know that? So I mentioned that there is some indication that there's a relationship between the tumor, the vestibular schwannoma growth related to hearing loss, and the corollary to that is vestibular schwannoma size, independent of if you have a growth curve. But those are not definitive relationships. There is, if you have a younger patient, they probably have a truncating mutation or one of the more severe mutations, and they probably are going to have more tumor burden, so that they are just at greater risk overall. The other factor is the multiplicity of tumors. So instead of one clean, perhaps maybe there's never one singular vestibular schwannoma, maybe it's always multiple schwannomas clustered together on the 8th cranial nerve. But the more tumor there is there, the harder that's going to be to either have a satisfactory surgical intervention or to treat those tumors, because they each have their own second hit in the NF2 gene. So they might not all respond to drug the same way. And then there was this really compelling paper that unfortunately we haven't had follow-up on, but it suggested that if there was involvement of the cochlea, even if there was a teeny tiny tumor, there would be a risk for hearing loss. And the last thing I'll address is across all of these papers, it's not even sufficient data for me to pull the charts, but there is a correlation between right and left vestibular schwannoma and right and left hearing, but it's very weak, and that probably has more to do with, are you a person who's at generally higher risk? So the risk is at the level of the person rather than at the level of the ear. So that brings me back to my pitch on the genetic severity score. I really do think that I am now getting this or calculating this on all of our patients and putting it into their chart, because it helps me think about how likely is this person going to need a therapy in the near term versus long term, and how should I be thinking about that in terms of the risks and benefits of drug therapy, the risks and benefits of surgery, the risks and benefits of radiation therapy. So I'm going to show you now that there are 2 studies that have applied this genetic severity score to clinical outcomes. And this one is measuring the growth rate of vestibular schwannoma by age and by genetic severity. And I'm going to highlight genetic severity score 3, because these are the truncating mutations. So this is either nearly absent or absent Merlin protein. And you can see that the growth, they have much more growth than the overall population earlier in life. So maybe these dark squares paired with these gray squares are where we get the commentary that you should have bilateral vestibular schwannomas before 30 years of age. And then if you're in these mosaic categories, remember that 1A and 1B are both mosaic, which means that we cannot find the NF2 variant in all the cells in your body. So it might be limited to only certain regions of the body. And those are highly variable, but mostly tend towards the growth is slow and variable and late. And then the 2A and 2B fall somewhere in between. And I'm showing you this because when you see growth on an MRI, it's worth pausing to say, well, what is this going to look like in 10 years? And unfortunately, none of us have been issued a crystal ball. But again, that genetic severity score may help us plot our individual patient on this graph. But I just told you vestibular schwannoma growth rate or size does not have a one-to-one correlation with hearing. So what about hearing? And I'm going to show you two pieces of data. This is just one study, again, from the Manchester group. This is at a single time point looking at 95 people with NF2 schwannamatosis by the AAO-HNS criteria, and then 143 people by their UK criteria. And so the blue bar is the UK criteria. Suffice to say that if you're in 5-6 of the UK criteria or CD in the AAO criteria, you do not have unmodified hearing. You need support for hearing, or you may not have no usable hearing. And you can see that if you're in 2B and 3, you're pretty much in the same area, that you're very likely going to have hearing deficits. And if you're in the 2A, it's a mix about how severe that will be. And if you're anywhere in the 1, there's some people will have complete hearing loss in that ear, but not all people. And this is, they were trying in a separate paper to predict the age of hearing loss by this genetic severity scale. And I do find this helpful in two ways. One is there's clearly a separation, again, between those mosaic and the truncating mutations, and then there's a gray middle area. But also, even in this setting, you can see a pretty wide range of variability. And when I speak to my patients who have the most severe manifestations, and I talk to them about hearing augmenting strategies like drug therapy or surgery or devices like cochlear nerve implants or auditory brainstem implants, I want to point out to them that if they're headed for this tract already, if they're on this path, then it is worth investing in becoming part of a hearing deficient community. And if it's uncertain where we're going to land, then we can debate the pros and cons of that. Recognizing that people who did not grow up in those communities, if that was not part of your primary education, it is very hard to learn American Sign Language or any version of sign language and make all of your friends, families, coworkers learn that in your 30s and 40s. Okay, so that's the natural history part of things. What do we do when someone is presenting with hearing loss and we know that they have NF2 schwannamatosis? And again, just highlighting that I am not so bold as to speak to surgical experts about surgical interventions. So I'm going to talk about drug interventions and some just what do we actually do in clinic. So first of all, when I get the MyChart message that someone says, I'm having significant change in hearing, I first ask the questions. What else is happening? Are you having sinus fullness, headaches? Has something else been changing? Because, for example, in a person who has multiple meningiomas and bilateral vestibular schwannomas, an alteration in intracranial pressure will change their hearing experience. If they have now an obstructive cause for their hearing change that has nothing to do with their cochlear or vestibular apparatus, that will change their hearing experience. And if I can fix those things pretty easy, hydrocephalus is arguably harder to fix than allergic rhinitis, but if I can fix those things without addressing the vestibular schwannoma, then I want to do that. So I always start with asking the compounding factors. And then, of course, while we're working on that, they need to have a hearing assessment and a visual inspection. So this is why it's so back to the multidisciplinary part of what I'm going to say that 1,000 times. I rely daily on my otolaryngology colleagues to help me understand, do they see a change? I recently had someone who had been getting multiple courses of oral steroids for hearing fluctuation, who actually developed a fungal infection of the ear and called with acute change. And I was anxious about that. And they live far away. They didn't want to come here. And we said, you have to come. And we were able to make the diagnosis of fungal infection. But I could not have done that without my partner in otolaryngology looking and making the diagnosis. I do want to say, for, you guys know this better than me, but especially for NF2 and especially with these confounding factors, these the word recognition score and pure tone average that we rely on are in fact subjective scores. It depends on how the stimulus is delivered, how active the patient is in responding. People who are not native English speakers will struggle in many cases with the exam. If they already have some other cause, they will struggle with the exam. So I often ask for repeat testing in 1 to 2 weeks if there's been a major shift in the audiology measures, because I suspect that there could be a testing, something interfering with the testing. Okay, but let's say we confirm that there is a hearing change or the patient is very concerned and they're far away from us and we need the time to get them here and get them evaluated. I do use glucocorticoids, although I will tell you I feel a little sick to my stomach every time, and that's because the evidence-based guidelines, which are the last reference here below, indicate no benefit. So I'm going to say that one more time. The evidence-based guidelines say there is no benefit from 3 randomized controlled trials of oral steroids versus doing nothing at all. And it's hard to believe that because I give people steroids and they say they're better, so I do it. But I just gave you an example of someone who had had multiple courses. I think she had 5 courses that led to infection. There are real consequences of these steroids. You have to be monitoring people closely, especially if you're going to do the regimens that were in these 3 randomized controlled trials, which were a 7 to 14-day course. Then people have to be weaned off. You have to watch things like glucose, especially if they have medical comorbidities. So I often in my practice will hedge and give a Medrol dose pack, even though that was in none of these 3 randomized controlled trials, because I'm just seeing if I can help my and our patients' psychology while I get the other things in place. And usually within 5 days, I can have them in our clinic with our team and our otolaryngology team. I can't get an MRI in 5 days unless something dramatic is happening, but that's what I've been doing, but that's nowhere in any evidence-based guidelines, so I'm telling you the evidence-based guidelines. If I've confirmed that there's a change on audiology 2 time points apart, then I go get the MRI, and we try to look at this cochlear signal. It's not always easy to detect, and then of course we measure the change in vestibular schwannoma. Ideally, the change in vestibular schwannoma is measured by volumetrics. Not every place can do that. I currently cannot do that. It's very difficult to assess change on linear measures for vestibular schwannomas. But let's say all signs point to tumor. Now we have to address the tumor. So how do I address the tumor? Again, my job in the world is to find and develop drugs for these tumors. And I've had the honor of participating in most of these negative studies. And so what I'm showing you here is not meant to be read in detail, but just to show you that since 2009 till now, we've actually had a remarkable number of studies, and only 3 of those have had a hearing response as the primary endpoint. The 2 that tested the drug bevacizumab, and there's 1 ongoing study testing the MEK inhibitor selumetinib, all are using hearing as the primary endpoint. Many of these studies did use hearing as a secondary endpoint, but you know what happens with secondary endpoints. It's nice if you get them, but you might not get them. So when we use hearing response as a primary endpoint, this is what we're using. We want to see then the delta in the 95% critical difference threshold. And because of this range that you're seeing here, to enroll on studies for hearing loss in the setting of NF2, you have to have less than 80% word recognition score. And if you've been less than 20% for more than 6 months, we don't anticipate that a drug therapy can bring back any hearing. So these are the 2 places where we have a ceiling and floor effect that affect our enrollment criteria. And then I'll show you this study, which was the first, this was a retrospective study by Scott Plotkin and his team that showed that there was hearing improvement with the drug bevacizumab in a retrospective group of patients with NF2 Schwannamatosis. And the reason Dr. Plotkin used this is bevacizumab is a therapy we use very commonly in the setting of glioblastomas. In the setting of glioblastoma, it does not improve overall survival, but it does improve progression and symptom control. And we wondered if that might have the same effect here. And part of that is because there was preclinical evidence that there is a pro-angiogenic phenotype of vestibular schwannomas. They take up a lot of contrast with MRI. They have dense, thick vasculature. And in the preclinical studies, if you treated with saline versus bevacizumab, we did see some thinning of that vasculature, exactly the same way we see in gliomas. And so that case series of 31 patients with symptomatic vestibular schwannoma showed unprecedented activity. We had multiple negative clinical trials with literally 0% of the patients enrolled having any hearing improvement or reduction in tumor size. And Dr. Plotkin's retrospective series showed 57% had a hearing improvement and 55% had a reduction in tumor volume as measured by volumetric 20% reduction. So just to tell you for a second what bevacizumab does, if you don't think about it all the time, VEGF is just one of the many circulating proteins that is a growth factor for everything, for our heart, for our brain development, for our nerve development. It also is a key driver of many cancers. And there is a circulating VEGF molecule, and then there are VEGF receptors. And Avastin works to gather up these circulating VEGF molecules. There are other drugs that work on the VEGF2 receptors. Interestingly, they haven't been particularly effective. For example, axitinib was recently tested in NF2, and we did not see excellent response. So we're seeing response if we block circulating VEGF, but not the receptor. Don't know why. So we had Dr. Plotkin's retrospective data. We needed to do a prospective study. We designed this study as you see here. These were the criteria. You had the most important is we were using hearing improvement as the criteria, as our primary endpoint. So you had to have hearing loss to enter the study, and that meant you had to have documented reduction in word recognition score less than 90% in the target ear within 24 months prior. So you had to show that decline. These were I already showed you the ceiling and floor effects. This is what we used for enrollment, and we used a 100 list word recognition score as our primary endpoint, with confirmation happening 3 months after. So if you had your assessment, and then everybody had to come back 3 months later to show that that was a real result. This is the schema. It was only 14 patients enrolled. They had to have those criteria I just mentioned. These are the sites that enrolled. They got treated every 3 weeks with this dose, and we did all of these assessments at all the time points that you see the bars. And then importantly, we stopped the drug and watched what happened off of drug, because we wanted to see how long we could hold the effect. The reason we did this specifically is we didn't know if we might fundamentally change something about the tumor. Unlikely, but that would be nice. And separately, bevacizumab is a monoclonal antibody. It is not cleared by liver or kidney. It has to be cleared by the immune system. So the half-life of bevacizumab is about 6 weeks. And we wanted to know, could we ultimately, in the long run, spread out the dosing? So the punchline is these are the results. Everything you see is the best response is in the dark blue, and these dots are their baseline word recognition score. And so what that came out to is that 5 out of 14 people had a confirmed response, meaning they had the response, and then 3 months later we did it again. And so that was 36%. You'll often hear us summarizing that, saying about 40% of people with NF2 can have hearing benefit from bevacizumab. That's this statistic. And what's interesting is that the hearing response rate in this very controlled prospective study was exactly the same as the retrospective study Dr. Plotkin had done at 57%. But if you want to know about durability and you get that confirmation 3 months later, the number falls by about 10%. So this is just to show you the change in speech discrimination on and off of drug. And what's important about this is that we do see overall improvement. You can see this one person had to come off of treatment for toxicity, and you can see the drop while they're off treatment. But otherwise, we see largely improvement or stabilization. And even off of treatment, we hold that improvement in their speech discrimination for up to 6 months, but certainly up to 3 months. How I use that information in real life is when I'm talking to patients and they need to have surgery for some other manifestation. Let's even say one side is responding to bevacizumab. There's been tumor shrinkage and hearing benefit, and the other ear is not, which does happen. And we need to stop the bevacizumab to plan for surgery. I can tell them with confidence, we'll be okay for 3 months. So you can stop this drug for 3 months and we won't lose anything. Similar results with tumor volume, although the growth was more steep starting at the 3-month time point. So again, there was not a direct relationship between tumor size and hearing, but basically we could, the median time to tumor shrinkage was 3 months, and we can keep that benefit for 3 months off of drug. The safety and tolerability is that only one of the patients stopped treatment due to toxicity. 14 of 16 completed all prescribed therapy. Another person, this person stopped because of toxicity, and another person stopped because they couldn't make it to the site anymore. And the median time to develop the most common side effect, which is hypertension, was about a year. And about 25% of patients required that we stop treatment or hold drug because of proteinuria. So this is what confirms that we have benefit with this drug. I will tell you it's since been studied in 3 follow-on studies of real-world experience, and the data holds up that we see benefit in just about 40% of people get a real hearing benefit where they will tell you my life is different. I don't use my hearing aids anymore. I do well at work, etc. And that we do see these cumulative toxicities, some of which require that we stop treatment. I mentioned that there's an ongoing study with selumetinib that is assessing hearing. Brigatinib and crizotinib are also assessing hearing. I can just speak to abstracts that have presented. Crizotinib did not see a hearing benefit. I have not seen any of the selumetinib data, and I'm going to show you the brigatinib data. These are 2 other drugs that have been tested specifically for NF2-associated vestibular schwannomas, and essentially there is no hearing benefit with everolimus. So if you're giving everolimus, you're giving it with the hope that you will slow or stop tumor progression. And with lapatinib, there was a hearing benefit actually, but it was assessed by pure tone average predominantly, and we don't know what to make of that because we don't have we can't normalize that to the data we have for other clinical trials, although we can normalize it to natural history study. And the number one reason this hasn't gained more traction is lapatinib is a very early stage EGFR inhibitor with a lot of toxicity in terms of rash and diarrhea. And so just the tolerability has decreased enthusiasm, even though we did see some hearing benefit. Okay, in my last couple minutes with you, I'm going to tell you about our ongoing study that I'm really excited about. This is, it's called Intuit for NF2, and this is a basket platform study. So what does that mean? The basket portion means that any tumor that exists in a person with NF2 can be included. So if you are a person with NF2 and you have a growing meningioma, that counts. Growing ependymoma, that counts. Growing non-vestibular schwannoma, that counts. Or of course, growing vestibular schwannoma certainly counts. But before this, all of our clinical trials were focused only on vestibular schwannoma. And as I showed you at the top of our time together, people with NF2 have a lot more than just vestibular schwannoma, even though that is the pathognomonic finding and a tremendously important quality of life issue for them. And then the platform part is to say we have one study design. We have the same criteria for getting on the study, no matter what the drug is that we test. And then we can have slots like you do at an airport terminal, and we can line up different drugs in those slots, which allow us to put in amendments for individual drugs, but not start all over. And in between a person being in those individual slots on an individual drug, we're collecting natural history data. So if they have surgery, we're collecting that data. If they don't have anything for 3 years, we're collecting that data. And the grand plan is hopefully one day, the people where we're collecting the natural history study on the master protocol will serve as the control group for any drug we deem of good enough quality to go forward with an FDA approval. So this is what that looks like in a pictorial form. Basically, any person who has NF2 has to have tumor progression of any one of these 4 tumor types anywhere in the body. And then they get randomized to one of the drugs. We only have 2 bins right now, brigatinib and neratinib. We're teeing up drug C. I also will make a pitch for all of you translational and basic scientists. We are always looking for the new drug, and any person who brings a drug into this consortium is the PI of that study for that drug, which is both an enormous honor and an enormous amount of work. So that's my public service announcement. And then we add drugs one at a time. And right now we have completed the brigatinib and we're in the middle of the neratinib. Okay, so I'm going to tell you about, this is the master design for all of, independent of the drug. We are going with radiographic response. That is not probably the best biologic endpoint, meaning people have to show us greater than 20% reduction in volume to have a response. And that might not be clinically meaningful, as we've discussed, but it's the only thing we can use that is objective that we can apply to all of the different tumor types. We then are assessing time to radiographic progression. Again, that's tumor size, hearing response in the vestibular schwannoma evaluable group. And then we're measuring NF2 quality of life measures, and of course, safety and tolerability for any investigational agent. So this is the brigatinib design. Brigatinib is an ALK tyrosine kinase inhibitor. It's FDA approved for ALK positive non-small cell lung cancer. it turns out we found this through a blind screen of NF2 positive cell lines and animal models. And the selection, that was through something called Sonodos for NF2. And the selection required criteria there was that it had to be tolerable and it had to work in at least 2 tumor types. And in our preclinical screen, it worked against meningioma and schwannoma. So this is the design, and we start with the original 20 patients. We need to see at least one person have a radiographic response. If nobody has a radiographic response, like our first 10 years of clinical trials in NF2, we terminate that sub-study. If we see at least one, we move forward with only 2 tumor types. We started with 4, we choose the 2 most promising, and that's the adaptive part. So here's where we are so far. We enrolled 40 participants. You can see the mean age was 26. I think we're getting a good range of severity. We are still calculating our genetic severity score, so I don't have that to show you. That's 165 tumors, of which 40 were target, because every participant has to have a single target, but we have an additional 125 non-target. And I mention that because it turns out that the non-target tumors often respond better, have radiographic response more than the target tumors. And these are unpublished preliminary data, but I'm happy to share them with you while we continue our analysis. So it might look different in the final publication, but you will see these are the tumor types. We had only 2 ependymoma. And in terms of response rate, the worst response rate was vestibular schwannoma. All of these, if you were a target tumor, you had to have greater than 20% progression in the last 36 months. And we did not see any vestibular schwannomas have a response rate. The 2 best response rates were non-vestibular schwannoma and meningioma. There are a lot of reasons why this might be. These are often people who have been heavily pre-treated, but we don't exactly understand that. And so this is what the waterfall plot looks like, and you can see what the overall change from baseline in percent looks like. In terms of hearing response rate, again, we measured that in all evaluable ears, which turned out to be, we could do word recognition score in 37 ears and pure tone average in 44 ears. And you can see the response rates here. They're not as good as bevacizumab, but they're respectable for a drug that we did not expect to be working that way. So further drawing questions about the relationship between tumor size and hearing function, or why there's hearing decline in people with NF2 vestibular schwannoma. I can tell you we did see a nearly universal slowing of the decline in hearing if we compare to natural history data, which we're still doing from this particular study, but against the literature, there is an improvement. In terms of tolerability and durability, 3 patients came off of treatment, 1 because they couldn't keep up with the demands of the clinical trial visits, which is a real issue for patients, and 2 because there was progression, radiographic progression of their target tumor. And you can see how many people required a drug hold. So 15 out of 40 is not nothing. So that means people had a symptom bad enough that we had to stop the drug. And in 2 of those 40, we had to reduce the dose. Fortunately, they maintained their benefit even at a reduced dose. And these are the range of side effects. So I'm going to wrap up with that very preliminary look at our data by telling you that hearing loss is a dominant manifestation of NF2-associated schwannamatosis. It is related to vestibular schwannoma behavior, but not directly correlated. And unfortunately, when complete hearing loss occurs, true deafness, it's often later in life. And that seems to be true even in people who have a severe genetic severity score that's high, meaning we have to be thinking about with our patients, what are we trying to achieve when we're protecting their hearing in their teens and 20s? And would we be better served, especially with people with this severe GSS, to refer them to a decreased hearing community earlier in their lives? And unfortunately, we cannot make any definitive statements about hearing and the hearing trajectory in people with NF2. And so that really does require a multidisciplinary assessment before and with intervention. The second thing I hope I'm driving home is we are better understanding the relationship between the genetic severity score and what people with NF2 will actually experience, including within hearing. And so I really encourage people, if you are seeing a person and you suspect NF2, please consider genetic testing and interpretation in collaboration with your medical genetics or team or genetic counseling, because it may indeed impact how you make decisions. And then I am happy to say that drug therapies can prevent a hearing decline in some people, and in the case of bevacizumab, and to date, only bevacizumab, can restore hearing in a very distinct subset of people while they're on therapy. It is not a definitive answer. It works while they're on therapy, and it is true that some people can stay on therapy for 20 years, but some people can't stay on therapy for more than 5 years because of the cumulative toxicity. So these still remain temporary solutions, and we still do not understand the mechanism of hearing loss in relation to vestibular schwannoma in NF2. Okay, how can we address those gaps? It remains that my number one goal when I'm meeting a person with NF2 and every time I see them is to look at the chessboard and preserve function in all of the nerves for which they are at risk for as long as possible, given a predicted natural history for that individual, which is really hard to do, but increasingly I am applying this genetic severity score to help me do that. And I'm really trying to prevent the untoward side effects from whatever we do. Drugs, I have a patient who I caused liver failure in by giving them a drug. They had to have a liver transplant. You all are well aware of the complications, short and long term, that can happen with surgery. And certainly with radiation, there are short and long term complications. So we just have to be thinking about that chessboard every time we make a decision. And as we move away from something as refined as chess and towards mousetrap, I'm showing this because I think we need a bunch of different solutions, because each person with NF2 has their own natural history that unfortunately we don't know when we're meeting them. But we need to be thinking of both creating and thinking about multiple choices for each person at each stage of decision making. There's not a one size fit all answer, which is why I'm thrilled to be here and working with all of you, because we do need all of us at the table. And long term, the goal is to have tumor prevention therapies. Brigatinib might be one of those. We'll see. We're hoping neratinib has a similar effect. We've only enrolled 6 patients so far, so we have no data yet. Gene therapy is on the horizon. That would be very exciting, although complicated. But I'll close by saying I am grateful and require a multi-specialty collaboration and community investment if we're going to get the best mousetrap we can get. And I will also say, for all of you who are looking for what are you going to study in your career, we do not understand the mechanism of hearing loss in NF2, and it is an area ripe for investigation. And with that, I will say thank you. I have a really remarkable team in our NF Center here, some of whom you might know. Pete Crichton and Brian Ward are my neuro-otology collaborators, and Dr. Plotkin has led a great deal of this work and shared several of the slides today, so I want to acknowledge him.